Good afternoon, everybody. It's great to see so many people here from so many different departments. Thanks for coming. And as you know, at these Dean's Lectures, we celebrate either the appointment or promotion of people who have been made professor in the last year. And I'm going to say this for your children and your family. 'Cause I always say this, but it's really a big deal to be promoted to professor here. It's hard to get on the faculty of Johns Hopkins University, and then once you're on the faculty, it's really hard to get promoted to professor because the decision is not made by us. It's really made by your peers around the world. We send out your CV and your letters. We send out a letter and invite people to weigh in. And so to get promoted here means you've received the affirmation of really experts around the world in your field. And so that's why we're here to celebrate Bill Moss. And you know, my speaking points say that Bill is one of the foremost experts in the world on measles, and that's how he was introduced to me, I think, in 2005. He was working on measles, and I went to visit him in Zambia. It was the first time I'd been to Zambia. And Paul Thoreau writes in Dark Star Safari, I don't know if you read any of the Paul Thoreau books, and one of the things he hates is that all these NGOs drive around these fancy white SUVs, you know, above the people. That was not a problem with Bill. So Bill had a van that embodied the word measles. I mean, it was pockmarked, it was scarred, and it had a 4-speed transmission that only had 2 speeds, and it was always, are we going to drop this transmission? Every time the driver shifted gears, we're going to drop the transmission on the street. So, you know, I felt really bad for him. I thought, here's this guy doing research around the world, and he's going to have to be towed, you know, from some dirt road. But he finally got that transmission fixed. But Bill is an expert in measles, but also in malaria. And one of the things that's happened, I think, in his career is he was working in Zambia in measles. He saw the need in malaria too, and so he's been able to span those worlds. And I'll tell you a little bit about his background. It's no surprise when I found this out that his undergraduate major was in religion and philosophy, and that sort of embodies Bill. Such a kind, at least at work he is, I don't know, but kind and gentle folk who really cares about others. You know, he embodies the altruism that we all value in public health. But he went to Wesleyan in Middletown, Connecticut, and then went to Columbia University where he got his MD and from the College of Physicians and Surgeons, and then did his MPH in the School of Public Health. And he was a practicing pediatrician in Harlem through 1990 and 1995 and cared for the sickest children possible, worked in the MICU. And when we were traveling that first trip, I think Sally O'Brien was with us, and we were talking about Sally's previous career. She used to work in development here, was to staff the royal visits to the U.S., and she was talking about staffing the royal visits. When Bill said he worked at Harlem Hospital, she said, I went with the Queen to Harlem Hospital on that visit. And I forget who was running the ICU. There was a famous pediatrician Margaret Haggerty, that the Queen visited, and they made rounds together. And Bill said, well, I was there too. I happened to be on rounds, and so it was this incredible connection, coincidence that you had been there with Sally, and neither of you knew it. So Bill then, after doing that, came to Hopkins as an ID resident, an ID fellow, and did that from 96 to 99, and then came on the faculty and worked with Diane Griffin during that time, and then came on the faculty here in the School of Public Health as an assistant scientist in both international health and MMI. And then around 2004, he transferred to Epi as a tenure track professor, and then was just promoted at the end of 2012 as a full professor. So I mentioned Bill's research focuses on several things. So one is HIV and pediatric HIV and the care of children in low-income countries with HIV, and for a long time studied the association of measles and HIV and the effect of measles vaccination on HIV. In doing that, he collaborated with people in Zambia at the University of Zambia School of Medicine, and he and I remember visiting there in 2006 or 7 and meeting with the dean of the School of Medicine and saying, you know, if there's anything we can do to help, we'd like to partner with you as a Johns Hopkins Bloomberg School of Public Health. And the dean said, yeah, we don't need you. You know, we have the University of Alabama. We just don't need you. And I went back about 5 years later after Bill had worked so hard and had built such trust. It was like suddenly when I went back, I was an old friend because I knew Bill Moss and all the work that Bill had done. And then and Bill has worked at both laboratory sciences, clinical research, and then field studies and epidemiological studies. He's published over 85 peer-reviewed articles, 4 books, and 22 chapters to his credit, and they're in great journals. And as you probably know, Bill is also part of the Malaria Research Institute and is a critical leader in the conduct of the field studies in the NIH-funded isomer study in Southern Africa, and has spent an increasing amount of his time working in malaria. So Bill's a first-rate person. He's a first-rate epidemiologist, but he's the kind of person who represents Hopkins so well in every venue. And so we're all excited when there's a measure of your popularity, how many people are here to sort of celebrate your promotion, well-deserved, to professor. So please join me in asking Bill to come to the podium.
Thank you, Mike, and thank you all for being here. So, there was actually Princess Di.
Oh, was it?
I'm going to show a picture of that.
Oh, yeah.
So, again, thank you all for being here. It's a wonderful opportunity to kind of reflect on my work over the past decade and a half. And there's a famous essay by a Russian intellectual historian named Isaiah Berlin called The Hedgehog and the Fox. And what he does in this essay is he describes, kind of categorizes thinkers and philosophers and famous writers as either hedgehogs or foxes. And he takes the metaphor from an ancient Greek poem that goes, and the fragment is something like, the fox knows a little about everything, but the hedgehog knows a lot about a big thing. And so I think that's kind of an apt metaphor for survival strategy in academia. You can either be a fox and try to diversify your portfolio and study a lot of different things, or a hedgehog and really delve deeply into kind of a single topic. And certainly in my family, my wife, Debbie Prasad, is the hedgehog. She's been studying HIV pathogenesis for decades, and I'm the fox. And I kind of, spread myself around and study different diseases. So being a fox kind of presents a problem for trying to summarize one's work. So I needed a kind of a conceptual framework here to kind of bring different lines of work together. And I wanted something kind of bold and a little presumptuous. So we have eradication as kind of the topic that kind of the conceptual framework or theme that I'm going to use to try to bring together 3 aspects of my work on measles, malaria, and pediatric HIV. So I do want to start, Mike referred to this, I kind of started my career after working 2 years as a pediatrician in Ethiopia at Harlem Hospital for 5 years in the early to mid 1990s in the midst of the crack cocaine epidemic. And part of the reason I went to Harlem after working in Ethiopia, I kind of liked the idea of being kind of a pediatrician in the trenches, was Margaret Hagerty, who's the head of pediatrics there, as Mike referred to. And she was this older Irish woman that loved to tell stories, and she was kind of this motherly figure, but could be rather stern and severe at times. But she was a great mentor, and she would always tell us that all that can be done is to care for each individual child one by one. And that was kind of her view from the trenches as a clinician, that children come in and you care for them one by one. And this is the picture when Princess Di visited Harlem Hospital with Margaret Hagerty. And I was there at the time. Madonna also came. It was kind of it was a very symbolic place in the 90s, Harlem Hospital was. It's kind of, both the good and the bad of African American culture and certainly the problems that plagued inner city New York at that time. including the crack cocaine epidemic and HIV, pediatric HIV and adult HIV, as well as TB. So this was kind of what I had, this was kind of my home when I came, and when I came to Hopkins and learned that you guys were saving lives millions at a time, it was like unbelievable. What a difference. Here we're going from trying to treat each individual child one by one, and this very different kind of public health perspective. And as I talk about eradication, what I'm going to do is kind of talk about big picture about eradication at the kind of the bookends, the front and the end of the talk. And in between, I'm going to talk about some of my work in collaboration with others, many of them here, and how that kind of feeds into thinking about eradication and elimination. So first, some definitions. The way people use the terms eradication and elimination are actually problematic. And there's a lot of ambiguity. There's disagreement on these terms. And I'm going to highlight that as I talk about measles and malaria and pediatric HIV, and how these terms kind of have nuances and subtleties that isn't often conveyed. But back in 1997, there was something called the Dallas Conference, and these definitions kind of came out of that Dallas Conference. And so eradication is the permanent reduction to zero of the worldwide incidence of infection caused by a specific agent. As a result of deliberate efforts, interventions are no longer needed. Elimination, and they also had a category, elimination of disease, so they distinguished elimination of disease from elimination of infection. So reduction to zero of the incidence of infection caused by a specific agent in a defined geographic area as a result of deliberate efforts. So these are kind of standardly used definitions, but they're problematic for a number of reasons. Some people feel that the distinction between eradication and elimination isn't a real one, and that we should just talk about national or regional or global eradication. There's a problem here with the reduction to zero of the incidence for elimination, and this was recognized shortly after the Dallas Conference. Because, for example, in like the United States, where we say we've eliminated measles, there's still measles cases, they're imported cases. We just don't see extended chains of transmission. So this definition is problematic for elimination, and and people adjusted the definition to account for the fact that unless there's global interruption of disease transmission, there's still a risk of importation. This notion of intervention measures are no longer needed also became problematic, particularly after the threat of bioterrorism, where something like smallpox, where we would originally say that we no longer need smallpox vaccination because the disease has been eradicated. That's no longer really a viable notion with the threat of bioterrorism. So some people created a distinction called, or a category called extinction. So for example, if the smallpox virus stocks in the United States and in Russia were destroyed, smallpox would become extinct. But even that notion has problems. Back in 2002, a group of scientists created polio virus de novo using a recipe that they got off the internet and reagents from a mail order catalog. So simple RNA viruses, certainly you can create, so even the whole notion of extinction of some of these pathogens becomes problematic when you can recreate them in a lab. So all that's to say is that I'm going to use the terms eradication and elimination, but they are problematic and they have subtleties, and I'll point them out for the different diseases that we're going to talk about. Many people agree that there are kind of certain key criteria to consider a disease for eradication. And so these are four of the major ones, the most commonly agreed upon criteria: that there's an effective practical intervention to interrupt transmission, such as a vaccine, but it doesn't have to be a vaccine; practical diagnostic tools with sufficient sensitivity and specificity. So we have to be able to detect the disease. We have to be able to detect outbreaks, for example, to respond to them. Absence of a non-human reservoir. The presence of a non-human reservoir obviously creates challenges in disease eradication. And then finally, some demonstration of success in eliminating transmission or interrupting transmission in a large geographic area. So these are this is kind of the framework for thinking about criteria for disease eradication. Another useful framework is to think about the feasibility of disease eradication. And I group these into kind of two broad groups biological, technical, and operational. And these are what are the areas I'm going to talk about most because they concern my research more. And certainly these you need to consider first. First one has to kind of agree that a particular disease, that it's biologically feasible to eradicate a disease. I'm going to come back to these much larger issues at the end of my talk. Certainly when these are in place, these become the kind of critical obstacles and challenges to disease eradication. So we'll end up talking about those. There have been a number of prior eradication efforts dating back to the early 20th century. I've highlighted in red smallpox and rinderpest. Those are the two diseases that have been eradicated using vaccine in deliberate efforts. Many people are not aware in public health, some people are not aware of the eradication of rinderpest. It's a veterinary pathogen, and eradication was declared a couple of years ago. I have polio in kind of this middle shade, and that's because people need to be aware that there are 3 serotypes of poliovirus. Type 2 poliovirus we haven't seen since 1998, and there have been no cases documented of type 3 poliovirus this year. So that strain may be, we may have interrupted transmission with type 3. Problem with type 2 is that we do have circulating recombinant type 2 vaccine-derived polioviruses, so that's still a problem. I want to highlight in my talk, and particularly as I go through my own research areas, the value of research in eradication efforts. And this was not always recognized and acknowledged. Many people comment on the failed malaria eradication efforts in the 1950s and 60s, and attribute that, at least in part, to a failure to have an ongoing research agenda. That eradication effort was driven in large part by the personality of Fred Soper and an understanding or belief that vector control through indoor residual spraying with DDT could interrupt transmission by reducing the lifespan of the vector, of the Anopheles mosquito. And the quip about the malaria eradication campaign in the 50s and 60s is that the only thing it eradicated were malariologists. And it really destroyed, as a campaign, destroyed the research agenda in malaria. And it has taken decades, really, to recover. Those of you who've heard D.A. Henderson speak or have read some of his works, he is a very strong proponent of having an ongoing research agenda as part of eradication efforts. And he, I think the most notable case in the smallpox eradication campaign or efforts was the development of the bifurcated needle, which allowed very easy delivery of the vaccine, 1/10 of the dose that was used prior. And that was something that was a development that occurred during the eradication efforts. I think polio was very late to recognize, the polio community was very late to recognize the need for an ongoing research agenda. In fact, it was only in 2008, I believe, that the Polio Research Commission was established by the World Health Organization, very late in the campaign. So there are eradication skeptics, or at least kind of voices in the wilderness, and I just want to highlight them kind of up front. And this is often framed as kind of a contrast between vertical and horizontal programs. That's kind of one conceptual framework to discuss this debate or talk about eradication campaigns being these very disease-specific vertical programs in contrast to more horizontal programs, primary healthcare programs. Back in the 1960s, a very prominent microbiologist, René Dubois, who was a very prolific writer, he got started off doing work in basic microbiology and made some fundamental discoveries there, but went on to really kind of devote his time to understanding the impact of ecology and environmental influences on human health. He was one of their kind of early skeptics about eradication, and he wrote a book called Man Adapting that takes this huge view of kind of human evolution and disease evolution, But here's a quote from that. Eradication of microbial disease is a will of the wisp. Pursuing it leads to a morass of hazy biological concepts and half-truths. So this was after, or kind of as the malaria eradication campaign was failing, the smallpox was just kind of was scaling up and developing. But he was a real critic of eradication campaigns. And I think he kind of saw it from an ecology point of view, and the view that there are these ecological niches, and humans can kind of manipulate them. If we remove one organism from this niche, another one will kind of come in and take its place. So we kind of saw it as almost kind of as a futile exercise. Carl Taylor, who many of you know, and Felicity Cutts, who was one of my early mentors in measles, wrote a very provocative article in 1997 in the American Journal of Public Health called The Ethical Dilemmas in Current Planning for Polio Eradication. And they kind of put forth the notion, at least for polio, who really benefits from the polio eradication effort. And kind of made the point, I don't have time to go into it in detail, but kind of at least raised the question that polio is not a major cause of morbidity and mortality in much of Africa and Asia. And that it was really the rich countries that would benefit from a polio eradication campaign because they could discontinue their vaccination efforts. So they're not really critics of eradication, but they at least raise some ethical issues around eradication. And then all of you know D.A. Henderson. I love that I got this nice picture of him from the web giving us a lesson. And many of you have heard him talk about eradication. And this was from a recent publication, a nice series of articles in the Philosophical Transactions this year on disease eradication. This was from an interview with him. I won't go through the whole thing, but is there any other disease that you would foresee being eradicated? No, other than smallpox. And then he does have this caveat down here about guinea worm eradication. But I think D.A. Henderson's view, if I can kind of summarize it, and some of you probably know it much better than I do, but he was very aware of the serendipity and chance that kind of went into, that allowed for smallpox eradication and all the things that could have potentially gone wrong. And also the disease characteristics of smallpox that made it amenable to eradication, the tool that was available, and some of the characteristics of the vaccine, its heat stability, the fact that you could tell whether people had a take with the vaccine just by looking at their arm. There are a number of features that he saw really kind of came together for smallpox eradication that really he doesn't see as feasible for other diseases. So I'm going to now move into the first of three diseases and talk about kind of my work in relation to kind of discussions, at least, of elimination and eradication around these three diseases. And I'm going to preface each one I kind of put what I think may be kind of the key biological feature of this disease that at least makes it very challenging for eradication. I think for measles, it's this basic reproductive number, which is a measure of the infectiousness of measles virus. It's a measure of the number of secondary infections that would occur if you introduced an index case into a completely susceptible population. So for measles virus, this is one of the highest reproductive numbers for a directly transmitted pathogen. And the consequence of this is that we need very high levels of population immunity in order to achieve in order to interrupt measles virus transmission. And I think that's really kind of the Achilles heel of any kind of global measles eradication effort. So one of the metrics for measuring progress in reducing the burden of measles is global measles mortality. And this is a model that was published last year in The Lancet, documenting the decline in estimated number of measles deaths. And there's no doubt that there's been enormous progress in reducing measles incidence and measles deaths throughout the world. As a consequence of getting the vaccine out. The solution to measles is actually relatively simple. Get 2 doses of measles vaccine to everyone in the world, and you will interrupt transmission. That's done largely through routine immunization services and through mass vaccination campaigns. Some of you may know that, and this is kind of one of the subtleties about this distinction between elimination and eradication. In September, so last month, the 6th of the WHO regions, the Southeast Asia region, set a measles elimination goal. So we now have measles elimination goals for all 6 WHO regions. Those are in black. These are rubella elimination goals in red. But for the dates in black are measles elimination goals for each WHO region. So de facto, we actually have a global measles eradication goal because all WHO regions have set an elimination goal. But it's not as simple as that. To actually declare a global measles eradication goal requires a very different process in WHO. The recommendation has to come from the Strategic Advisory Group of Experts. It has to go to the Director General. The World Health Assembly has to have a specific vote that they're going to make a global measles eradication goal. And that would then bring in global resources to achieve this goal. Right now, these are individual regional goals. But it is kind of one of the interesting subtleties that now all regions have declared an elimination goal, but no one's talking about a global measles eradication goal because the process for setting that, the political process for setting that is different. There are a number of challenges to measles eradication. I've talked about the high transmissibility requiring high population of movement, high population immunity. We have some technical challenges in terms of disease detection. We could have better diagnostics. I'll talk about that briefly. But there are a lot of operational issues that hinder our ability to achieve high vaccine coverage and thus high population immunity. One of the first things that WHO had to do in terms of convincing both the Strategic Advisory Group of Experts and then ultimately the World Health Assembly was to first consider whether measles was biologically feasible to eradicate measles. And I worked with Peter Striebel, who leads the WHO efforts on measles control, to kind of think through the biological feasibility of measles eradication. And most experts, and we were in agreement, think that it is biologically feasible. But I want to point out that the more you kind of dig into these issues, there are more complexities and nuances that come out. And I think that's where the value of ongoing research is. This is just a list of kind of theoretical biological challenges to measles eradication, persistent human reservoirs. I won't go through all of these, but we're not aware of any persistent reservoirs that are infectious. But for example, we know that people with subacute sclerosing panencephalitis harbor measles virions, at least they're defective virions, for many, many years. So there is kind of a precedent, at least, for kind of long-term carriers, if you will, of measles virus. I'm going to focus on a lot of my work, kind of my little research corner in this field was trying to better understand the impact of the HIV epidemic on measles control. And I'm going to talk a little bit about that and my work in that area now. So HIV and measles can interact in kind of two broad ways. The HIV epidemic can impact on natural measles or wild-type measles virus infection, or it can impact on measles vaccination. And this is just an outline of various ways in which HIV can impact on clinical measles. So it can alter the clinical manifestations of measles because the clinical manifestations reflect the immune response, the cellular immune response. So in children or adults who have impaired cellular immunity, they could get measles without the characteristic rash. There's evidence that it increases disease severity and mortality. Some of our work in Zambia demonstrated that. There's reports coming out of South Africa during the last big measles outbreak they had of measles inclusion body encephalitis, which is where the virus is actually replicating in the brain in patients with, in adults with AIDS who actually presented with measles inclusion body encephalitis. Another way is if HIV-infected children with measles were infectious, had a longer infectious period, that could alter our ability to control measles. And we tried to get at this question with studies in Zambia and hospitalized children with measles. It's actually very difficult to measure the infectious period of a particular pathogen. So we often use surrogates, and we use the ability to detect measles virus RNA in various body fluids, whether it's blood or urine or nasopharyngeal swabs. What this figure shows are two histograms. These are the numbers of children in each group. They're relatively small. This reflects HIV-infected children, HIV-uninfected children, and this is the percent of children in these two categories in whom we could detect measles virus RNA more than a month after the onset of the rash. And the standard dogma at the time actually was that measles virus is cleared within several days after the onset of the rash. So we were able to detect at least RNA at least a month after, and in 90% of HIV-infected children, but about half of the uninfected children. So this suggested two things. One is that there seems to be some persistence of at least measles virus RNA. It's not clear whether these children are still contagious or not, and that this persistence occurs in a higher proportion of the HIV-infected children, but at least suggestive that the infectious period could potentially be longer in this group of children. Diane Griffin's group has gone on to, in a monkey model with Wendy Lin, to really look at this persistent measles virus RNA, and it's quite fascinating because it really alters our standard thinking about measles virus infection, which we typically think is an acute infection. And the measles virus RNA has this kind of bimodal peak, and it's really unclear what that virus is, whether that's really infectious virus and where it's hanging out. This is less important for eradication efforts or control efforts, but an interesting question is to actually turn the question around and ask what's the impact of measles on HIV. And I report this because not many people are kind of aware of this, and it was quite a striking finding. We were measuring HIV viral loads in these children with measles. This was prior to the introduction of antiretroviral therapy in Zambia. And we expected to see a transient increase in plasma HIV viral loads during acute measles, because we know measles virus causes this intense immune activation. In fact, we saw the exact opposite. We saw measles virus, acute measles virus infection actually suppresses HIV replication. Now, we don't recommend that HIV-infected children get measles for this reason. It's very transient. But this was our initial study where we measured, this is in 33 HIV-infected children hospitalized with laboratory-confirmed measles. These are plasma viral loads here. This was when they were admitted to the hospital, when they were discharged. 1 month later, this was a plasma viral loads in a control group of children without measles. And we were very surprised to see this kind of transient suppression of HIV replication. This was one of our children in a subsequent vaccine study in who we had viral loads kind of before and after measles. This is now on a log scale. This is age in weeks. We've got a plasma viral load, 10 to the 6th. These children have enormous plasma viral loads of HIV. Got measles vaccine in our study, but then like 2 days later was hospitalized with measles, and we were actually concerned that that child was actually sick with measles vaccine virus. We sequenced this virus and showed that it was a wild-type virus, not vaccine virus. This child recovered and then basically went back to their set point in viral load. This is the type of decline you actually see with highly active antiretroviral therapy. I mean, it really shuts off HIV replication. That's kind of a side story. The big public health impact of HIV epidemic on measles control is through measles vaccination. And these are some of the ways the HIV epidemic can impact on measles vaccination. If there were lower rates of vaccination in children of HIV-infected women, and we think this may have been the case early on in the HIV epidemic before a lot of the care was built through the PEPFAR program and other programs to deliver care to these children and antiretroviral therapy. These children born to HIV-infected women lose their protective maternal antibody earlier at a younger age. which has kind of a double-edged sword. It makes them more susceptible to measles at a younger age, but it also makes them perhaps more likely to respond to the vaccine because they don't have the inhibitory maternal antibodies. I think the big one are these higher rates of primary or secondary vaccine failure. And I'll show you results of a study there that we did on this. This was with Felicity in the London School and Diane Griffin. And what we have here is time since measles vaccination. Again, this is before kind of PEPFAR got into Zambia and there was widespread access to antiretroviral therapy for children. This is the proportion seropositive. We have three groups of children. The uninfected children, who are children born to an uninfected mother, the HIV seropositive children who were uninfected but born to an infected mother, so they had maternal antibody, and then the HIV infected children. And the bottom line is all three groups of children responded to the vaccine. Children developed protective antibody levels. These were based on plaque reduction neutralization assay. But the HIV infected children, and the confidence intervals get big because these children are dying, but basically they don't maintain immunity. And this was one of the interesting things about wild-type measles virus infection and also the measles vaccine is that it induces very long-term immunity. But these HIV-infected children weren't able to develop the B cell, the memory B cell immune response to sustain high protective levels of against measles. So we have these kind of, what was interesting, and we thought a lot about this, could these HIV-infected children who are getting vaccinated against measles but losing their protective immunity over time, could they build up a pool of susceptibles that could allow for sustained measles virus transmission? And we think that in the absence of antiretroviral therapy, what was happening was that there was competing dynamics, and these children were just dying. So they never build up that pool of susceptibles to sustain transmission. And these are Kaplan-Meier curves that Katie Sutcliffe did based on that same cohort that we studied the measles vaccine responses in. And basically, this is the survival curve of the HIV-infected children at the time of vaccination. So they could never build up the pool of susceptibles. So working with colleagues at initially at the London School, we built a dynamic age-structured compartmental model and basically modeled what's the impact on measles prevalence if you introduce antiretroviral therapy. These children survive longer, but they don't recover the protective immunity. And that's what this model is showing. This model, what we have here are prevalence. This is a prevalence per 100,000 of measles, different age categories. The black bars represent HIV uninfected children, and the kind of the white section, the HIV infected children. What I want you to see here is that in this model, which basically just increases the survival of these HIV infected children, you introduce antiretroviral therapy, and there are more cases of measles. So basically, with antiretroviral therapy, you can get this paradoxical effect because you're allowing these susceptible children to survive longer, so you have more susceptibles in your population, you have more measles if there's an outbreak. So we next tested this first in a population-based survey, and this work was done by Sarah Lowther when she was a doctoral student here. And this was kind of cool. We did this with Frank Herrera and Tim Shields. This was one of our earliest attempts of using satellite imagery to establish a sampling frame. So we used this satellite image of this densely populated urban township in Lusaka, Zambia. Sarah dutifully tagged more than 16,000 structures in this relatively small area. And then we could pick a random sample of households and also look at spatial patterns as well. What we did was we did an oral fluid survey because we knew if we tried to collect blood in this population, we would have a lot of refusals. So we went in, we collected oral fluid and looked at antibodies for both measles virus and HIV and tried to look for an association at a population level between basically asked the question, are HIV seropositive children more likely to be measles seronegative? And in this study, the odds ratio was, adjusted odds ratio was greater than 1 for that association, but it didn't achieve statistical significance. So we kind of interpreted this as kind of confirming our hypothesis that prior to antiretroviral therapy, these children were just dying and not, the susceptibles were not surviving to be a problem for measles control. The next study we did that was led by Caitlin Rainwater-Lovett, who was a doctoral student in the department, is now a postdoc with my wife, and was basically to look at the effect of antiretroviral therapy on measles immunity. So again, at a clinic in Lusaka, Zambia, we enrolled children who were starting antiretroviral therapy, measured their measles immunity, measured measles antibody before starting antiretroviral therapy, and then followed them over time and looked at measles immunity. I give Caitlin a lot of credit for staying with this study because it got very complicated, because at the time we started this study, there hadn't been measles in Lusaka for several years. And right in the middle of this study where we're looking at measles immunity, there's a huge measles outbreak, and they do this mass vaccination campaign. So it became very tricky to tease out what was the effect of antiretroviral therapy, what was the effect of exposure to wild measles virus, and what was the effect of revaccination during these campaigns. I won't go through this in detail, but these are lasagna plots that Caitlin made, and these are study children, and if they're green, they're IgG positive, measles IgG positive. If it's red, so this kind of tracks individual children over time. This is what happened temporally when we had the big measles outbreak and the supplemental immunization activities, the mass vaccination campaign. But in short, we found no evidence that immunity to measles recovered after receiving antiretroviral therapy, which was the hypothesis we had going in, that antiretroviral therapy is going to prolong survival, but is not going to kind of reestablish. There's not going to be it's not going to reestablish measles immunity. Subsequent to this work, the ACIP in the United States has come out within the past couple of months with a recommendation to revaccinate HIV-infected children after receiving after immune reconstitution with antiretroviral therapy. I'm a member of the WHO SAGE working group on measles and rubella, and that's kind of the next thing I'm hoping to move that group to, is to come out with a global recommendation that HIV-infected children who are receiving antiretroviral therapy should be revaccinated against measles. I think the solution is relatively simple here. So there are a number of measles research needs, and one of the things that I do, kind of stepping back now and thinking about the measles elimination eradication agenda, one of the tasks I was given on the working group was to try to set the priorities for a research agenda. I'll tell you, this was one of the most difficult things I ever did, because there's no right way to set prioritization criteria, or there are a lot of different kind of ideas on how to do this, but it was very tricky. But I just want to point out that a lot of the so we basically had a survey that went out to a number of experts, and they had to prioritize different research questions. A lot of these are operational, and it's really around getting the vaccine out, having good surveillance systems, and really understanding reasons why people refuse to have measles vaccination. There are a number of new tools that are kind of on the horizon, and I think where that could make our control efforts or elimination efforts easier in terms of vaccine delivery systems. One of the exciting things are these microneedle patches. I don't work in this area, but these are these polymer-based little squares that have kind of these pointed edges on them. You put dried measles virus on them, you put it on the skin, they actually dissolve within a minute or two. They're very easy to administer, they're heat stable, and there's a group from the University of Georgia working with Paul Rhoda from the CDC that are trying to move these forward. And this would be, I think, a big advance in getting measles vaccine out using this microneedle delivery system. I think another thing that would be a big advance, and there are a number of groups working on this, our point of care test for measles diagnosis. Just to show you one example from a group from the UK, I mean, it looks like a malaria rapid diagnostic test, but I think having a point of care test that could detect measles IgG antibodies, measles IgM antibodies would be a big advance out in the field for detecting outbreaks. And I'm currently working with a group from Boston that's developing their own point-of-care test that we're hoping to field test in Zambia. So I'm going to switch, that's kind of a quick run through kind of measles. I'm going to switch to malaria and talk about progress in malaria elimination and some discussion around malaria eradication. I think that one of the key kind of biological features of malaria, and particularly Plasmodium falciparum infection, is the high entomological inoculation rate. And the EIR is the number of infectious bites per person per year. That's how it's often framed. And I want you to think about this because in some areas of sub-Saharan Africa, the entomological inoculation rate is as high as 300 to 800. And what does this mean? This means that in some places, there are children who are being exposed to Plasmodium falciparum every day for a whole year, or sometimes twice a day for a whole year. There is no other infectious agent that has that intensity, where there's that intensity of exposure, where you're exposed once or twice a day, every day for a year. And I think this is one reason why Plasmodium falciparum has had such an enormous impact on the human genome, because of this very intense exposure. Now, malaria eradication is a very controversial phrase, and I think there's a lot of misuse of that phrase and ambiguity in that phrase, because malaria is a disease that's caused by at least now five agents. And certainly, so the canonical four, Plasmodium falciparum, Vivax, Ovale, and Malariae. The most recently identified one, Plasmodium knowlesi, which is a zoonotic infection, but many people now think is the kind of the fifth human malaria parasite. When people talk about malaria eradication, they're certainly not talking about eradication of Plasmodium knowlesi, because that has a large animal reservoir. It's even more complicated when you think about species such as Vivax ovale that have a latent stage in the liver hypnozoite stage, and we have no way of detecting people who have the latent stage, the hypnozoite. So talking about malaria eradication in terms of Vivax is also problematic. But I think most people at least have in their mind when they say malaria eradication are talking about Plasmodium falciparum, which is the species that cause most deaths. So this is a map from the Malaria Atlas project of Plasmodium falciparum endemicity in 2010. I want to point out two things. One is that people talk about shrinking the malaria map. If you look at a similar map 100 years ago, this would extend way up into Europe, into Russia, China, up into the United States. 100 years ago, malaria was common in Baltimore. So there's certainly been, over the past century, a dramatic kind of reduction in the geographic area of Plasmodium falciparum. And Randall Packard calls this the making of a tropical disease, because now it's kind of refined in the tropical areas. This reflects parasite prevalence in children 2 to 10 years of age, and the red is the highest prevalence, basically 70% here. And so you can see there are foci in East Africa, spreading across Central Africa into West Africa, with very high levels of parasite prevalence. Basically, 3/4 of children are infected all the time. So there are a number of challenges to malaria eradication. But there's no doubt that many countries have eliminated malaria. Countries are making progress toward malaria elimination. It's this kind of central, these tropical area that's most challenging. And so this is just this is not an exhaustive list, but some of the challenges are the microepidemiology. So the epidemiology of malaria is very focal, and it's driven largely by the vector and the vector's behaviors. And you can have villages a kilometer apart with very different epidemiology of malaria. So this notion that kind of one size fits all, one particular strategy is going to be useful around the world is not really appropriate here. Another big problem is asymptomatic reservoirs. As people acquire clinical immunity, they can carry the parasites without clinical manifestation. And if one's really talking about elimination, one has to be able to identify and eliminate the parasite reservoir from these people. I'm going to talk a little bit more about that. There are emerging problems with insecticide and drug resistance. Our rapid diagnostic tests are imperfect. And we have problems with getting people to sustain various vector control strategies such as nets. So I'm going to talk about some of our work in southern Zambia to try to understand this asymptomatic reservoir. This is an area where the burden of malaria has declined dramatically over the past decade, and there's talk about creating malaria-free zones. The government of malaria has talked about creating malaria-free zones here, and so we've done some work to try to better understand the asymptomatic reservoir. So these are strategies to try to get at that reservoir. Passive case detection, this doesn't do well to get at that reservoir. You're just waiting for people to come to the clinic, they get tested and treated. Reactive case detection is where if someone comes to the clinic, you send a healthcare worker to their home, and they either test and treat everyone in the home or some defined radius around that home. And the assumption here is that malaria is spatially clustered, and so that you detect these foci of transmission. The next kind of step up is just to do massive test and treat. And they've done this in some districts in southern Zambia, where basically you just go through the community, test everyone, and treat everyone who's RDT positive. The last approach that has also been tried is massive drug administration, where you don't even bother testing people, you just treat the entire population. So we've done studies in rural southern Zambia, an area called Macha, to try to understand the epidemiology of malaria there and these asymptomatic reservoirs. This is a picture of what that area looks like. And basically, we do these community surveys, again, using satellite imagery as a sampling frame. We administer a questionnaire with Doug Norris, collect the mosquito vector, assess whether people are using nets, and then we collect a blood sample, a dried blood spot sample, and measure parasitemia by rapid diagnostic test, anemia, gametocytemia, and antibodies to malaria. So I'm just going to briefly go through this. This is an analysis that Katie Sutcliffe did, basically looking at, we had two study designs. We had a longitudinal study design and cross-sectional. And in the longitudinal study, we repeatedly tested and treated those individuals over time. The cross-sectional study, we just did people once. And we looked to see whether the risk of malaria decreased in the houses that we repeatedly tested and treated, that we followed longitudinally. And I won't go into much detail here. This was a high prevalence season and area. This was lower prevalence. But basically, when we adjust for season, we can see a protective effect. What this is showing is a protective effect of going into households and repeatedly testing and treating. Basically, you're interrupting the transmission within that household. We next look to see what proportion of RDT positive individuals would be identified if there had been this reactive case detection strategy. If we had sent a healthcare worker to every home where there was a symptomatic individual, tested and treated everyone there, what reduction would we see? And again, we would, in the higher prevalence area, maybe close to half of people we would detect. In the lower prevalence area, maybe a little under a third. And so this reactive case detection strategy, at least by this analysis, would still miss a large proportion of asymptomatic carriers in this area. This analysis was carried further by Kelly Searle, who ran some simulation models. What this is showing is the satellite image of the area. Each of these dots are households, and then she drew buffer zones kind of around these households and assessed what proportion of infected individuals would we capture if we did reactive case detection out to 500 meters or out to a kilometer. And basically, if you went out a kilometer, which would be very labor intensive to do, but you'd get the vast majority of asymptomatic cases in this area. Now this strategy, one way to kind of target this strategy is to use a malaria risk map and try to identify hotspots of malaria transmission. So this is work we did with Tim Shields and Greg Glass, creating a malaria risk map that identified hotspot areas, these kind of orange areas And that's another way to kind of refine the control strategies here, is to go to areas where the transmission seems to be greatest. We're now working in collaboration with the National Malaria Control Center and an NGO called ACROS that is implementing, as part of program, a reactive case detection strategy in this area of southern Zambia to try to create these malaria-free zones. And we're working with them now to try to develop ways to assess how effective this strategy is and how many asymptomatic infections they're actually missing. So there are a lot of research needs in malaria, in new insecticides, I think is high on the list because of the emergent insecticide resistance, drugs. We could talk for an hour on vaccines. I won't do that. Strategies to identify hotspots, but we could answer any questions about that. And then I think critically is getting community participation in these efforts. And that's another thing that D.A. Henderson kind of highlights in talking about smallpox eradication, was getting the community's involvement. And we actually have a medical anthropologist working with us in the Isomer, who's now working with ACROS, that NGO, to try to understand kind of community health worker perceptions around this strategy. I'm just going to end up quickly talking about pediatric HIV. I think the biggest challenges here are the incubation period, so we can't identify infected people easily, and obviously the latent reservoirs, which are the challenge for cure. There is, the UNAIDS has put out a global plan towards the elimination of new HIV infections among children, with a goal of reducing new HIV infections by 90% by 2015. This is kind of an interesting use of this notion of elimination. It's elimination of a disease, and it kind of has more parallels with discussions of elimination of neonatal tetanus, where you're eliminating a disease in a particular age category. But this is kind of the trajectory, kind of where we are at now. There has been progress in reducing numbers of new HIV infections, but they're still estimated to be over 300,000 new pediatric HIV infections globally, largely in sub-Saharan Africa. The biggest advance would be actually being able to cure pediatric HIV. And I just wanted to highlight kind of the work of my wife, who's kind of been on the forefront of this. These are HIV viral loads from the famous kind of Mississippi child, who was the baby that was born in Mississippi, got treated very aggressively very early on, but had detectable virus, and this is the decay curve. And then, for those of you who know, that some of you may know the story, but was taken off therapy by the mother, and then came back into care. The pediatrician tested the child, or measured the HIV viral load in that child, and it was undetectable. Did multiple repetitions, and basically that child has come off therapy and has not had any rebound plasma viremia. So this is one area in which this work is going, but I'm not involved in that. But I've been working in southern Zambia more on kind of operational aspects of getting, of understanding care in very rural Zambia. And this was work done with Katie Sutcliffe and Janneke van Dyke, first looking at barriers to care for HIV-infected children in rural Zambia. And what I want to highlight here is this is travel time in hours. And a fair proportion, actually the y-axis got cut off here, but a fair proportion of children were it took more than 5 hours for them to get to the clinic. And it just reflects the poor access to care in this type of area, and how we're going to and challenge the delivering preventive services. We also looked at survival of these children. These children get on antiretroviral therapy. This shows their CD4 counts. This shows the proportion of children who are suppressed. I'm sorry you can't really see this well, but these are suppressed with viral suppression 6, 9, 12, 18, and 24 months after starting antiretroviral therapy, and the different colors represent increasing travel times. And what we found, you can see basically those children who traveled more than 5 hours to the clinic were less likely to achieve virologic suppression. So again, the problems in delivering care in this type of rural setting. We've now been looking at decentralized care in this setting, moving care to the outreach clinics, and this just reflects travel time, and this shouldn't be surprising, but you move the care, you decentralize the care out of the hospital, and you dramatically reduce the travel time. And these children have done fairly well. Again, the proportion of children who achieve virologic suppression seems to be somewhat slower than those who receive care centrally. The study we're currently working on now is looking at early infant diagnosis. These are, this top figure reflects the time from when a sample is collected for early infant diagnosis in a child to when that test result is returned to the caretaker. And you can see in this rural area, it's over 3 months. And if we're going to institute early effective therapy, we need to shorten this time. So we've been doing a study with a P24 ELISA and measuring turnaround time. Here you can see the turnaround time with this test. Now we're just using this for research purposes, but was 22 days compared to 44 days here with the standard HIV and DNA test. So just by doing an enzyme immunoassay at the clinic, we could reduce the turnaround time by half. Now, there are much better point of care tests for early infant diagnosis in children than this enzyme immunoassay. So this is kind of a proof of concept here, but in the near future, there are going to be point of care tests. So we currently have a grant under review, Katie Sutcliffe and I, to really evaluate prevention of mother-to-child transmission using something called Option B+, which is where all HIV-infected pregnant women are given highly active antiretroviral therapy. And so we're going to look at various health system models if we get funded, if the government comes back. That's a lot of caveats. But look at a point-of-care test and use mobile phone text messaging to try to set up a surveillance system for adverse birth outcomes. So there are a number of pediatric HIV research needs, particularly having new drug formulations. I've talked about point-of-care diagnostics. I think we need better strategies to identify HIV-infected women and their infants in order to really achieve this goal of elimination. And then again, community knowledge, attitudes, and practices. So I've come to the last part of my talk. I want to kind of step back and look at these kind of social, political, and economic considerations. And the first point that I want to make, and I often say this to students when I'm talking about measles, is that successful public health programs undermine themselves. And the disease burden goes away, and the donor interest wanes, and the political and public commitment wanes. And I think this is going to be a big problem for measles and trying to achieve any kind of global measles eradication goal, is as the disease burden goes down, it becomes less of a concern. The problem with measles, as with many other diseases, you relax your control efforts and it comes right back. Just to highlight that, this is recent data from the CDC on measles in the United States in 2013. In 2011, we had more measles cases in the United States than we'd had in the prior 10 years, in the prior decade. We're on track in 2013 to meet that. Now, these aren't huge numbers, but it reflects importation and susceptible pockets within the United States. And the big problem, as many of you know, is vaccine refusal or vaccine hesitancy in the United States. And so of US residents with measles who were unvaccinated, a large proportion declined vaccination because of religious or philosophical reasons. And as the disease burden goes down, we may see more and more of this globally. This is a big problem in Europe. It's now an increasing problem in sub-Saharan Africa, where we have these pockets of communities that refuse vaccination. I want to point out that there are also large-scale kind of geopolitical changes that I think affect disease eradication goals. And I see disease eradication as probably the most cooperative human activity ever undertaken. I can't think of another activity that we engage in that requires such global, individual level cooperation. There was a paper that had published in Foreign Affairs in 1993 called The Clash of Civilizations that eventually came out in a book by Samuel Huntington, who was a professor of government at Harvard. that kind of lays out kind of this new kind of geopolitical framework. And it's a nice soundbite, the Clash of Civilizations. And basically what he's talking about is that over Western history, kind of wars were first fought between kings, then between nation states, then between ideologies such as fascism, communism, liberal democracy, and now we're in a world that's a clash of civilizations or cultures. I have here one book on the Cold War. I just want to point out, and D.A. Henderson makes this point, of where the smallpox eradication kind of agenda came from. And I want to make you aware that that actually came out of Cold War politics. This is again from that quote from interview with D.A. Henderson, but it was really the Soviet Union that first proposed smallpox eradication. They had been out of the World Health Assembly for a long time. They kind of rejoined, and in 1958 it was Viktor Zhdanov who really first proposed that we eradicate smallpox. And I think the Soviets were probably looking to make some impact, and this really came out of this Cold War politics. The other thing, that this eventually went to votes at the World Health Assembly. They needed 58 votes to pass the resolution to eradicate smallpox and had 60 votes. A little better than Congress does, but it was just by a narrow margin. And so we're in a completely different world now. I don't think it's not by accident that the last case of smallpox was detected in Somalia, in the Horn of Africa. Ethiopia had a civil war at that time. These are polio cases. They're all type 3. And it's not an accident where these are now, in northern Nigeria, in the Horn of Africa, on the border of Pakistan. And so we're faced with these are enormous challenges for eradication, as to how do we now get this global cooperation in a geopolitical climate that's so adversarial. And I don't need, this is just kind of one extreme example of that. This is from just 2 weeks ago, where polio vaccinators were killed in Pakistan. And so the targeting of vaccinators by the Taliban or other extremist groups is really an important, I think, changes the playing field for disease eradication. What's the future of eradication? I leave you with more kind of questions than answers. It's a very complicated issue, and we need to be very careful if we embark on eradication goals. And I think the hesitancy of the World Health Assembly to declare a measles eradication goal, despite the fact that all 6 regions have measles elimination goals, reflects this kind of uncertain political climate. It's also a fact it's also a consequence of the failed polio eradication campaigns. But just a couple questions: who benefits? Who pays the price? What are the ethics of eradication? Is eradication the best path to equity? And really, what are the alternatives? And I'll just end. I know I went over. When D.A. Henderson had published his book, he had a signing here, and I got him to write to me, "Good luck with measles eradication," which is probably the only time he acknowledged the possibility of eradication. So I'll end there, and thank you for staying with me past 5.
Well, you said you liked lots of different things, and proved at that talk. I mean, it was a great talk. You were allusions from literature and history. It was great. So I think probably people have lots of questions. You just mentioned in passing, the intensity of infection with malaria is the reason why it's had such an effect on the human genome. So you're talking about hemoglobinopathies there?
Yes.
Yeah.
Largely. I mean, it's had effect on the HLA types as well, but mainly hemoglobinopathies, exactly. Yeah.
Great. So I'll throw it open, and I'll ask people to use a mic so it's recorded. So, Neil, do you want to, let me give you this mic. And you pass it over.
So, Bill, I agree, that was great. as you know, many of us have thought that measles can and should have been eradicated. Would we be much better off if we had started with measles rather than starting with polio? And based upon all the criteria needed to fulfill, measles should be easier than polio.
Right. No, I agree with you. I think measles certainly has its challenges, and as I said, the infectiousness is one, but it doesn't have some of the complexities that we have with polio, particularly the large proportion of asymptomatic individuals, the prolonged shedding of poliovirus. We have a problematic vaccine with the oral polio vaccine, which is easy to administer, but has its own problems in terms of recombination and virulence, reversion of virulence. I think measles would have been easier than polio. My understanding, and you may know better, how that it was the U.S. that really pushed the polio eradication campaign. That there was a lot of public interest in the United States and at the CDC to put the polio eradication on the agenda.
So let me ask you that slide you showed of the GIS of the areas of malaria transmission around villages. So if you overlay the vector positivity on that, does it look the same? So if, instead of using transmission, you looked at vector being infected with malaria.
Yeah, so I can answer that. So that malaria risk map. There was a postdoctoral student of Greg Glass named Julie Clennon who created a risk map based on vector breeding sites in the same area. And the two risk maps look remarkably the same. Yeah.
So I have a question based on your background and your data. If your undergraduate major was in philosophy and religion, and the major objections to vaccines are, as noticed from your slide, are philosophical and religious. So the question is, what do you think are the prospects for increasing adoptability or acceptability of vaccines? And is that going to go up in the future or down in the future? And what might affect that? As public health people, what can we do?
Yeah. That's a great question, Joe. So my sense, I think we're going to see more vaccine hesitancy. I mean, Neil and Dan Solomon work in this area. And I think in part it's as the disease burden goes down, I think people, first of all, there's misinformation about vaccine safety. And second, people try to make a risk-benefit choice. And when they don't see the disease, in their minds, the risks of the vaccines go up. I think there is a lot that can be done. I mean, some of it can be done through regulations, and such as school requirements. And each state has different requirements. There can be regulations on travel. I've heard discussion, so take for example the last big measles outbreak in Canada that was imported from France. Countries spend enormous amounts of money dealing with imported measles cases. And so in terms of outbreak investigation and control. And someone has kind of tongue-in-cheek said, maybe half-truth, said, they should be sending the bill to the countries that import, from where it was imported. I think as public health people, the big problem, another person who's written and spoken a lot about this is Paul Offit. I think public health professionals can do a lot. I think we don't do a good job in kind of getting the benefits of vaccination out. And it's very easy in the media to say, take a child who has autism and the parent relates it to MMR vaccine. Those groups, those anti-vaccine groups, are very media savvy, and I think the public health community has been slow or not as good as using the media to promote the benefits of vaccination.
So I'll just follow up on that. Yesterday we heard a talk here, was it remarkable woman, Becky Landa from KKI, talked about detection of autism in infants, physical signs that predict, motor control and things like this, which really which demonstrated to me, I don't know, Al was here, I know, that it has to be present at birth, because she can predict very early, what kids are going to move to autism. So Neil, do you want to say something?
No, I agree. The misunderstandings. The other thing that we don't have is good education of our general public about. We don't have good education of the general public about science and how we establish causality. There is a lot more that we could do as professionals to help improve that. There's lack of understanding of causal assessment in our healthcare professionals who don't have that. So there's a lot of work that might be done in the near future.
Yeah, and it's not only a lack of understanding. I mean, we've seen prominent politicians who are anti-science. So it's not like we just have to educate people. You have people who have this as a philosophical and ideological basis. A couple of people know that I was once offered, not too many years ago, a lot of money by a prominent socialite in New York, not anybody connected with this school, so to make that clear, not the famous anonymous donor, to settle the question of vaccination and autism once and for all. Design the perfect study, get everyone agree to it, and then end this controversy. And people like Neil and others, I thought, well, this is a gift from heaven. Until I talked to people who really know this, and they said it's a fool's errand because no matter what you do, you will not answer the question because they will change the question. They keep moving the goalposts on you. And so you can design a perfect study to prove X, but then they'll say, oh, it really wasn't X, it was actually Y, and you got it wrong, even if they agreed that it was X at the beginning. So it's a difficult task.
Well, I think people can talk for a long time, Bill. It was a great talk. So let's move it out to the gallery. And I do want to recognize your wife, Deb Prasad, and your two wonderful kids. Thank you for coming and helping us celebrate your dad's accomplishments. Okay.